Yeah, I don't know if you should believe him if he tries to sell you a used car, because he's good at exaggerating. Anyhow, maybe a quarter of the number of publications he mentioned. And my disclosures are much fewer than Scott's also. So just a quick background, because we're going to do an update on the treatment of venous thromboembolism. So you know that there is a high incidence of venous thromboembolism, and depending on how the statistics are done, you can get 350,000, you can get 600,000 per year, and the deaths also depends on if you do autopsy. Nobody does autopsy anymore, so that's a problem to get accurate data. But we know that the population is aging, and you've seen this already, that with increasing age we have a logarithmic increase in the risk of venous thromboembolism. And you've seen this, Zweig's prediction that by 2050 we'll have a doubling of venous thromboembolism, partly because of the increasing age in population, but also because we're doing more complicated interventions with our patients. We're keeping our cancer patients alive longer, and we're giving them combinations of different therapies where each one of them is prothrombotic. The treatment of venous thromboembolism, just quickly in a historic perspective, because it's always good to have the history behind you. What are we without history? We don't have much data from before the last century. We have pictures, we have maybe some art productions, but we know that we started the 19th century, or the 20th century rather, with recommendations to keep patients in bed, elevate the leg, and put maybe hot bandages on the leg. Keeping the patients in bed when they have DVT is maybe not the best idea if you can treat them, but if you can't treat them and you're worried that it's going to embolize, maybe it was a reasonable idea at that time. Well, in 1937, back in Sweden, where I grew up, we started using unfractionated heparin, initially for heart surgery, Clarence Crawford, and that became widespread, effective. And then in 1941-42, several simultaneous publications on the first vitamin K antagonist, dicumarol, which was later in 1947 replaced by warfarin, and it's been in clinics, of course, for 60 years. And then we got the low molecular weight heparins about 20 years ago, and that was a revolution. Because you didn't have to give intravenous, and even if you gave subcutaneous, you could give it once a day instead of several times a day with unfractionated heparin, and then the NOACs or DOACs. And with the latter two, we have an increasing possibility of treating the patients as outpatients, which dramatically decreases the cost of care. And so I'm supposed also to talk about the ASH guidelines. Unfortunately, they are not published yet. They've been out for opinions, but they are not official, and I can just give vague previews of it. I'm not really allowed to talk about all the details, but I mean, this is obvious that the ASH guidelines will point out the benefit of outpatient treatment, although it's not for all. So there are patients who will need to stay in the hospital still. Okay, PE, we have heard already about the PERT, and this will be partly a repetition of what Rachel informed you about. So the initial management of PE, but already starting with diagnosis. So we have increased the use of CT a lot, and we think that in our hospital, as soon as a patient sneezes, it's a CT scan. So no wonder that the mortality rate, which Rachel Rosowski showed you, is going down for PE when you do CT on everyone and you find the minute subsegmental PEs that we didn't even find before with a multi-slice CT scan, without the multi-slice CT scanners, and we didn't treat them. And now we find them and we treat them, and there's no surprise, they don't die. Well, I mean, they didn't die before either. So those statistics of decreasing mortality, you have to take with a grain of salt. But how can we reduce the use of CT in the ER? And we cannot use just clinics, because just the clinical point of view, I mean, signs and symptoms are not enough, but together with D-dimer, so a negative D-dimer, 28% of the CTs can be avoided with a low Wells score or low Geneva score. And then you can refine it a little bit more by doing, for instance, age-adjusted D-dimer. So we know that the D-dimer goes up with age. So if they're over 50, easy rule, you take the age of the patient, 75 times 10, so 750 becomes the cutoff, and then you can avoid 33% of the CTs. There are other proposals also that maybe by the pretest probability, if it's moderate or low, you can have different D-dimer cutoffs. We're testing that also in a study that is finishing next week with 3,000 patients, and we'll see how that comes out. In pregnancy, pregnant women, you cannot use the D-dimer. It's going to be high in almost all of them, so it's not really worth it. And so the pregnant women, we do the imaging diagnosis. You can do it with VQ scanning, or you can do it with CT. And regarding VQ, it's had a bad reputation for many years, and that's why we went to CT scanning. But the VT SPECT, single proton emission computed tomography, is as good as CTPA. And if you add a low-dose CT scan to VQ SPECT, it becomes even better. So VQ SPECT, if you have it, is not a bad thing. An alternative that is useful, meta-analysis of 8 studies, shows that it's doing in sensitivity better, probably, than anything else, and in specificity, not second to any other tests. So we have 2 options. So now high-risk PE. So these are you can call them massive, others want to call them hemodynamically unstable. So the systolic blood pressure is less than 90 millimeter mercury. And if you don't have all the sophisticated possibilities that Mass Gen have, I'm sure that you have thrombolysis. I'm sure that you can do systemic thrombolysis intravenously, and then just go with intravenous. You can do it quickly, and you can save lives. The studies are very small on these patients, but everything points in the direction that thrombolysis saves lives. Yes, it increases the risk of hemorrhage 2 to 3-fold, and unfortunately also of intracranial hemorrhage. So we do need to inform the patient before we start it that, yes, you run this risk, and have the patient with you, patient preferences. Are you in agreement with this treatment? It's a quick question, hopefully a quick answer from the patient. And we can do it in pregnancy also. There are multiple case reports, even small case series of pregnant women, and it's an increased risk of hemorrhage, but you can save 2 lives if you prevent the mother from dying here. So now we have the very high risk PE. So those are patients who already had a cardiac arrest, for example. They're not just hemodynamically unstable, and we get the question sometimes, what do we do here? And yes, if you have the PERT team, you have all the options, but I think that for those who don't have quick access to surgery, to embolectomy, to interventional radiology, it is quick to give a bolus dose or a very quick infusion of TPA. And I've seen a patient who was extremely unstable like this, a young woman, oral contraceptive triggered pulmonary embolism, and she was on, they had started intravenous heparin. They were discussing with a thoracic surgeon to do some operative intervention, and while they were discussing, the patient passed away. So, always take into the consideration the option of giving a quick infusion, and Sam Goldhaber was one of the pioneers there, and there are several randomized studies now showing that the quick infusion over you can give it as a bolus or over 15 minutes or so, and it's typically around 50 milligram of TPA that can also save lives. So you saw this already, and I'm becoming more and more convinced. I'm going to bring this into my hospital. We don't have it yet at Hamilton General Hospital in Canada, but we need to start PERT at our site also, and so when a severe PE is identified, to not be in the situation that Rachel told you about, that depending who is paged by the ER physician, the treatment goes that way or that way, but that we have a quick discussion. And that model, when you have several options and quick access to several options. We don't have ECMO, but we have most of the other options. And you saw this also, so just one number to call and the whole team or part of the team is activated. This seems to me like the ideal way to go forward. Congratulations, Rachel, for your success in this respect of getting so many centers already doing this. So then we have the hemodynamically stable, but with right ventricle strain. And I know that there are many physicians who feel that they want to do something, and they think that thrombolysis will solve the problem, but the PATHO study actually showed that this isn't a solution, because for all, we are not sure exactly how to select correctly the patients with just right ventricle strain who benefit from thrombolysis, because in the PATHO study, yes, they decreased the composite endpoint, but the main part of the composite endpoint was actually rescue TPA, whereas they increased the risk of stroke and of major hemorrhage. Oops, what happened there? Okay. Now, for the DVTs, for the large DVTs, we have also options. We can give them the usual low molecular weight heparin, we can give them NOACs, or we can think of thrombolysis or catheter-directed thrombolysis. I think most of us feel that for a large DVT with significant symptoms, we're not ready to start them directly on NOACs. We would give them the benefit of parenteral treatment for 4 or 5 days. Now, we don't have direct randomized clinical trial support that this is better than NOAC, but subgroup analysis from the Hokusai VTE trial and from the Rivaroxaban, the EINSTEIN trial, actually gives us evidence that the large PEs, they benefited from having initial heparin, low molecular weight heparin treatment. And those patients would anyhow stay in the hospital for some days. And also the large DVTs where there is a lot of inflammation, and we know that the heparins have pleiotropic effects, additional effects to the antithrombotic effect. They are anti-inflammatory and they have anti-apoptotic and other effects, and that could actually benefit those with large DVTs and PEs, decrease maybe the platelet activation and the spasm in the arteries, and improve the outcome of those patients. So for the large DVTs, there were a few studies that looked at thrombolysis, catheter-directed, and a meta-analysis that was presented recently showed that there are improved outcomes regarding patency and post-thrombotic syndrome. And then came the even larger ATTRACT study that was published very recently, and there, big disappointment that there was no difference between pharmacomechanic thrombolysis, so the combination of through a catheter giving thrombolysis plus a catheter that fragments and absorbs the clots, sucks up the fragments, and often they put stents in there also in the iliac, common iliac vein if there was a narrow area, Turner syndrome. But very disappointing, although I was in the event adjudication committee, and we were all actually discussing this while the study was going on, that there were too many clots that were not sufficiently proximal. So we would have liked to see just iliac or common femoral iliac. We saw clots that were distal femoral, and I'm not sure that the intervention was beneficial for those patients. So I think that for some patients it might still be of benefit to reduce the risk of post-thrombotic syndrome, but because of the overall results of that ATTRACT study, the ASH guideline is not going to really favor this intervention. NOACs, well, we have had the phase 3 studies with the different NOACs, and we have had meta-analysis, several of them, and then we get finally Cochrane analysis also, and it shows that there are benefits with the NOACs, but when you go to the ACCP guidelines from 2016, Clive Kieron, so there is a suggestion to use NOACs. Why that? I mean, we have the decrease of intracranial beats. It was absolutely clear in the AFib trials that with NOACs, you decrease the intracranial bleeds by 50%. And when you meta-analyze the VTE trials, you also get this 50% decrease of intracranial bleeds. There are very few in each trial because the treatment was shorter than in the AFib trials, 6 months. In the AFib, they were usually on it for 2 years. The AFib patients were older, higher risk for intracranial bleeds, but if you meta-analyzed these VTE trials together, you could see exactly the same. So it's not diagnosis dependent, it is a class effect of the NOACs that they reduce the risk of intracranial bleeding. But it's a small absolute number. We go from 4 per 1,000 on warfarin to 2 per 1,000 on the new anticoagulants. So absolute numbers are small, but it's there. We cannot use the NOACs for some patients, so not for pregnant women, not for breastfeeding women, not in the very severe renal failure. I mean, hemodialysis, I absolutely agree with what John said before. I would not give it to those patients. Mechanical heart valves, when they get a DVT still, they have to remain on warfarin. And the strong inducers, strong inhibitors of the PG glycoprotein or CYP3A4. And then the body weight. So there was an ISTH guidance document that said that for patients over 120 we shouldn't give unless we measure their level, because it had been, though very few of those were in the studies, and I'll come back to that. Then the compliance, okay, that's a problem. If we have patients that we know already that those are going to be poorly compliant for other reasons, it could be better to put them on warfarin. So I've had patients who have substance abuse, severe substance abuse problems, and we have put them on warfarin, and if they live close to us, we bring them back to our point-of-care clinic, and they get personal attention every week, every 2 weeks, written instructions, and it doesn't work in all of them, but for some of them where I thought this is never going to work, I was surprised. We had some of them 100% of the time in the therapeutic range with warfarin. So with this personal attention that we have with warfarin, for some patients that we worry about compliance, that warfarin can work. We have no idea if the NOAC is going to work for those patients. So what about the morbidly obese patients? And we are having more and more of them. You have lots of them. I was a few months ago in Australia, and I stayed with my daughter who lives there in Randwick, which is near Bondi Beach, and I just saw these very fit people jogging everywhere. I gave a lecture at a hospital which was a bit further in Sydney, and I said that you don't have this problem, and they laughed, and they said, you're seeing a selected population at Bondi Beach. If you go further in west into Sydney, you'll see more obese people than you have ever seen before. So it's everywhere, and it's in the developing countries also. It's in China, it's in India, obesity is worldwide, so we need to know. And usually the phase 3 studies on the NOACs from the AFib and the DVT, they showed patients split into a very low weight and then maybe 50 to 100 kilos and above 100 kilos. But most of those above 100 kilos were between 100 and 120, and we really don't know what happens with the morbidly obese, so over 120, or you use pounds over 260 pounds. And that's what the ISTH guidance says, no, don't use them there. So the Dresden NOAC registry by Bayer Westendorf, he was the one who published the surprise study that you heard before, very prolific publication guy, and he had 3,000 patients there with all kinds of body weights, and 1,000 had a BMI over 30, and he showed that sure enough the cardiovascular risk factors increased with the BMI, but then if you look here at the event rates, and he split them up into so you see the lowest is BMI over 40, so these are morbidly obese. And you see that the effectiveness endpoints, that's all kinds of thrombotic events, it was the lowest event rate on NOACs, standard dose, in these morbidly obese patients. You see 0.5, and then it was 1.56 and 1.84 with the lower BMIs. And so this, yeah, so you see it there, but perhaps more bleeding in those. So this is contraintuitive. I mean, they should have a lower plasma level of their NOAC, and this is called the BMI paradox. And we don't know exactly the reason for this, but we can give the standard dose. As John Fanicos before alluded to, that you shouldn't tamper with the labeled dose, and we can feel quite safe going up. I think we're doing levels now, 10A levels, and dilute thrombin levels in these patients just once, but we see therapeutic levels in these patients up to at least 140 kilos, 150 kilos, so up to at least 300 pounds or 310 pounds. We don't see any problem with the levels, and this study also indicates that we can safely give those patients NOACs at the standard dose. And the cancer subset in the VTE trials indicated that we have good efficacy. We might even have a better efficacy than warfarin. That was versus warfarin, and it was a subset, and it wasn't planned for patients with cancer, so these patients were probably better, not as aggressive cancer patients as you see in true cancer trials, but maybe doing a bit better, as in the top thing there. Actually, the meta-analysis showed that they did better on the NOACs. It favored NOACs compared to vitamin K antagonists, but with bleeding, it was equivocal. That was against warfarin, and now we got the Hokusai cancer, VTE cancer trial that Scott already presented to you. Now, there is a big methodological problem with it. They used a composite endpoint. And when you put two endpoints there, it's okay to use a composite endpoint where they are of the same nature, like the cardiovascular, the MACE, stroke, and heart attacks, and so on. But when you put endpoints that go in opposite directions, bleeding and thrombosis, into the same endpoint, this is a methodological problem. You shouldn't do that really, unless you're convinced that the new treatment is going to reduce both, and you have biological plausibility for it doing that. And as you saw from the results, they went in opposite direction. So now I can imagine that maybe they reasoned when they planned the study that low molecular weight heparin Yeah, it can go in both directions. It could give more bleeds, and it could give more blood clots. But I don't think there is a biological possibility for it. I think it is a problem, and it also becomes a little bit of a problem when you have the patient and you're going to say this was a non-inferiority study shown. It did show that the NOAC edoxaban was not worse than the low molecular weight heparin, but it gave more bleeding than low molecular weight heparin. That's if you truly quote the results. I mean, it was a little bit worse. It was significantly worse regarding the bleeding, regarding hazard ratio. It was a little bit, and it was a bit better, but not statistically significant with efficacy. And although the curves at the end look like they have the same distance between efficacy and safety, so one is significant, the other one is not significant, but that's the way you get the hazard ratio, because the hazard calculates the whole time. You can see that the curves for the hazard ratio separate earlier, so you have a longer time with the separation there between them. Now, you do have what Scott already told you, the subgroup analysis showing that it was the GI cancers that led. And if you look at the non-GI cancers, there was the same risk of bleeding. So for those patients with non-GI cancer, you don't have any disadvantage. You have maybe the small advantage of borderline reduced risk of recurrent VTE, and you have, at least for us, I think for you also, lower cost and much better convenience. And then the Rivaroxaban study, which I'm going to present to you because although it's not published, they have presented it at several conferences already, these slides, and they are public domain. So, and they published the methods paper also. So SELECT-ED was planned for 530 patients, but they had to reduce it because slow recruitment, so it became 406 patients. They called it a pilot study. I mean, 500 patients, cancer patients, is a pretty big pilot study. At the last conference when they stood up and said that, Harry Biller stood up and said, you must stop calling it a pilot study. So it was also the same dalteparin regimen, the clot regimen, and against the standard dose of Rivaroxaban used in the VTE studies, and 6 months, and then they planned a second randomization for, okay, I'm not going to show that, but for patients at 6 months to randomize them again, and they had to give up that because at 90 patients. Those are extremely difficult, the extended treatment in cancer patients. Anyhow, so they are essentially duplicating the result of the Hokusai VTE study with slightly better efficacy with the Rivaroxaban compared to low molecular weight heparin, and the hazard ratio is actually significant. And then with the bleeds, there is an increase statistically significant if you take the major plus non-major bleeds. That you have there. And, okay, so that's the second randomization at the extension. So there are many more studies to come. These are all the studies I'm aware of. So 4 studies for the acute treatment, and there are 2 who are daring enough to go for extended duration and randomization, but it is a randomization that might be easier than the previous because it's not placebo, it is between a higher and a lower dose. So all the patients will get active treatment, and that might be helpful to get them on board. So this is the chronic lunch debate at conferences. The duration of anticoagulation, and I've been asked to stand up and speak for the shorter and sometimes for the longer, and, and you have to adapt your thoughts to what you don't believe to or believe in, and so we have the ACCP guidelines, and they were previously very firm, and then in the newer iterations, there were methodologists that got more impact, and the methodologists pushed the content experts towards a more moderate, modified opinion. So the grades dropped significantly, and recommendations became often suggestions. And I mean, we all agree if a patient continues to have repeated events or has cancer, yeah, we give them extended treatment as long as they have active cancer. But otherwise, there are these hesitations for patients, especially. We have to go according to preferences, values and preferences. There are some that don't want to be on anticoagulation forever. We can talk to males who have a 70% higher risk than females, that you, with an unprovoked DVT, should remain on anticoagulation indefinitely. But there are young males who are active in sports, who play hockey or American football, and they say, I'm not going to be on anticoagulation forever. That destroys my life. Because after all, what we can show is that the lifetime risk of a recurrent event, if they have a DVT, unprovoked DVT, is 50%. So 50% will be treated unnecessarily. And they will say, I'll take a risk of a recurrent DVT. Maybe a bit worse when you have a PE, because we know that if the initial presentation was PE, the recurrence in 75% of the cases will again be a PE. And the same thing with DVT. If you had a DVT the first time, the next one will most likely be DVT. Why is that? We don't understand 100%. So additional risk factors for recurrence. I said already male sex. We can use other prognostic factors. We can use the D-dimer, and I've used also a lot this D-dimer when you plan to stop, maybe at 6 months, and if it's negative, which it should be because the patient is still on anticoagulation, then you stop and you do a new D-dimer after another month, and if it's negative, you tell the patient there is a very low risk. But Clive Kiron in the Dodd study showed that, well, for men, it didn't really work, because even if, so that's the top curve, even if they were negative at 1 month, this was unprovoked VTE, they had a high risk of recurrence. So it wasn't that useful for men. It was quite useful for women. And for those women who had estrogen-related, so pregnancy or hormone intake-related VTE, they had an extremely low risk of recurrence, and you don't need to do the D-dimer. They just have the lowest risk of recurrence if they're not pregnant again, or if they don't use estrogen-containing hormones again. They have an extremely low risk, so you can just tell them, you'll be fine. You have a very low risk. But for women who had an unprovoked VTE, you don't know why, so they are sort of 5% risk of recurrence next year. Do you think that's too much? then you tell the patient maybe you should continue. But do you think it's not that much? And that's where values and preferences come in, what the woman thinks is worthwhile. So we can have a discussion. And many women who had a big PE, they will say, I'm dead scared. I don't want to come off anticoagulation. So you'll continue anticoagulation in those. So now we have a little bit more of an option when we can offer them the NOACs that are easier than warfarin, and we can discuss the low-dose NOACs that you already heard about. So the Amplify extension study compared versus placebo 2.5 and 5 milligram BID, and you can see that efficacy-wise, 2.5 and 5 milligram, they were exactly the same and much better than placebo. And then regarding bleeding, they were also very similar to placebo. And you can say that there maybe is a little bit higher risk with the 5 milligram, but it's not statistically significant compared to the 2.5 milligram. And in the Einstein choice trial that you heard about, then we again get the same picture, but against aspirin, that you get very similar result in efficacy for the half dose, the 10 milligram as a 20 milligram in efficacy, and in safety also. I mean, when you, as Scott did, magnify the scale, it looks like a difference between them, but it's 0.1%. So it's really, they're all the same. I mean, very reassuring. They are very close to, they are the same as low-dose aspirin. Most people will not hesitate about taking a baby aspirin per day, so why not take a low-dose anticoagulant once a day? Now, there is no statistically significant difference in efficacy and in safety regarding bleeding and regarding the recurrent VTE between the full dose and the low dose, the half dose. So the ASH guideline, and the studies were not powered really to tell if there was a difference between those two. So the ASH guideline is going to say you can give either or. And how are you going to decide? So my take on it is that if you're more worried about the risk of thrombosis, you continue with the full dose. And if you're more worried about bleeding, you go down to the half dose. But you also have patients, finally, where you're not going to give any anticoagulation to begin with. So, and this is a discussion. We have these more and more sophisticated methods, as I mentioned, with the CT scans, and that we have also with ultrasounds, that you can go further down and you can find tiny clots in the leg, and it depends on why you do the ultrasound. But if the patient has significant symptoms, you're going to treat the patient. But if the patient had minimal symptoms, or there could be another reason for the pain, and there is a very small distal DVT, you might not treat. And so the ACCP guideline says that that is an option, especially if there is a risk of bleeding also by treating. And so we have a table with both, and this is taken actually out of the ACCP guidelines, summarizing these additional risk factors when you should treat. And it's important to know that for patients with cancer, you do treat. You do treat small clots, you do treat even incidental clots, because they're showing from sub-study of the Hokusai VTE cancer study, and from other studies, they're showing that incidental PE in cancer has the same bad prognosis as symptomatic PE in cancer patients, so you do treat them. And compression stockings, a difficult topic. Patients might not like when you say put on a compression stocking and wear it for 2 years, 1 year or 2 years. Those rubber stockings, it's itchy, it's sweaty, it hurts in the below the knee. I'm not going to do that. The SOX study, which was done from Canada, but there were also centers here participating. The SOX trial, which was methodologically, I think, perfect. It used placebo stockings versus real stockings. They asked patients what they thought they were wearing, and it was 50-50. They really didn't know if they were wearing placebo or real stockings. The study staff did not see what they were wearing because the day they came for the follow-up, they did not wear the stocking, and so on and so on. There were all kinds of methodologically minute things there that they thought of, and it showed no difference at all in post-thrombotic syndrome, no difference in recurrent VTE. But a systematic review was done then recently on all the studies, and unfortunately some of the studies were too poor methodologically, they couldn't use them, but there again, I mean, no convincing evidence that compression stockings are of benefit. I still think that for patients, we should see them not probably a few weeks, a couple of weeks, a month after the VTE. If they have significant swelling still, they might, for the swelling, benefit from some time use of stockings. But we shouldn't give it immediately, because then they get a stocking that after 2 weeks or 3 weeks is too big for them, and they have to buy another stocking. So, ladies and gentlemen, in conclusion, VTE, epidemiologically an increasing problem, and just like obesity, an increasing problem. We have different risk scores. We can use them well, and algorithms, and PERT, you can consider that for if you have any possibility, and NOACs will come more and more. We will start using them in cancer patients. I think doctors are already voting with their feet for NOACs in cancer patients. Thank you.
Two quick questions.
This full or low dose DOAC, you mentioned for extended treatment, I think makes sense. What about low dose warfarin for extended?
Yeah, so that has been evaluated, and the ELATE trial showed that it was less effective than a full dose, standard dose warfarin. So I'm not using it for any patient in venous thromboembolism.
Any other questions?
So I have a question about the BMI-2. The ISTH guidelines caution people of using the DOACs greater than 120 kilos or a BMI greater than 30. And in the graph that you showed, it looked like the VTE risk was lower, but the bleeding risk was higher. So are you using it in patients over 120 and with a BMI greater than 30?
So we do use it independent of how much they weigh, but we do check a level. peak level. So we asked the patient to take the morning dose. They have to be on it for 3-4 days at least, so we reach a steady state. And then we asked them to come in 2 to 3 hours after. And if the peak level is above the population median trough level, and that's complicated. So they did PK studies in all the big trials, and from the whole population, they got a median trough and a median peak level. And if this patient's peak level is below the median trough level, then we figure that, well, most of the time they have a too low level. That's not good. But we have hardly ever seen it. We have done it now in 40 patients, and we had one patient who was below that level. So I think that we can use it. Now, we don't have as big patients probably as you have. You might have patients. My daughter is doing residency. Now she's in Boston, it's better. But when she was in Baltimore, she had patients who were 500 pounds, 600 pounds, and I don't know about those patients. But yeah, I don't know if that's true, that they would bleed more. It's also totally counterintuitive. Maybe they bleed because they have other morbidities and that cause them to bleed more. Maybe, I mean, probably they have all these cardiovascular risk factors. They must be on aspirin also, these patients, or clopidogrel, and maybe that's why they bleed more. I mean, it wasn't a randomized study, this was registry study, so I think that they are selected, they have more cardiovascular risk factor, and they have additional treatments. Okay.
Thank you.
And Harvard Medical School, and I'm also the president of the North American Thrombosis Forum, NATF. I've been fortunate enough to be invited to this annual conference for many years now, and we've decided to team up and devote the second half of the program to a topic that at NATF we're absolutely passionate about, which is preventing pulmonary embolism and preventing DVT. We're going to be presenting you with a lot of new data this afternoon, but our first task inform everyone that the VTE prophylaxis problem's not yet been solved. In order to explain this to us better, I have the pleasure of introducing my colleague and my friend, Dr. Umberto Campita. He is a vascular medicine cardiologist in our section of vascular medicine at Brigham and Women's Hospital and Harvard Medical School. And he's going to really set the table for this afternoon. Series of presentations. His talk is in protecting our vulnerable medically ill patients during hospitalization and after discharge, a critical, unrecognized, and unmet need. And I believe, Umberto, this is your first time in Dearborn.
It is.
And the first time at this conference. Let's give him a great